we then have Dr. Aparna Rajgopalan to speak on refractive outcomes in high myopes, comparing BARRET 2, SRK2 and Wang's-Cox adjusted SRK-T.
Good evening, everyone. I'll be presenting refractive outcomes in high myopes comparing BARRET Universal to SRK-T and Wang's-Cox adjusted SRK-T. Cataract surgery in high myopes can be challenging because of the postoperative refractive surprises and patient dissatisfaction. The older generation formulas can lead to refractive surprises when used in high myopes because of the errors in calculating axial length, ELP and IOL constants. The newer generation formulas like BARRET Universal 2 can give satisfactory result after cataract surgery in these patients, but it could be used only in advanced machines like IOL Master. So, our aim is to study the refractive outcomes in high myopia patients with axial length greater than 27 mm undergoing phacoemulsification and in-the-back IOL implantation using BARRET, comparing BARRET, SRK-T and Wang's-Cox adjusted SRK-T. So, ours was a single center retrospective study. EMR of the patients with axial length more than 27 mm and with a minimum postoperative follow-up of 3 months was evaluated. We evaluated the demographic data, pre-op BCVA, spherical equivalent, anterior segment, posterior segment findings and post-op refraction. A-scan biometry was done using IOL Master 700. In case of media opacity, axial length was calculated using immersion biometry. IOL power calculated with BARRET Universal 2 was implanted in all eyes, and then biometry was repeated using SRK-T with actual axial length and Wang's-Cox adjusted axial length to know the residual refraction. The optimized axial length equal to 0.8453 into measured axial length plus 4.0773. We excluded those patients who underwent SICS, post-refractive procedures like LASIK, secondary IOL implantation, those who were left FA kick, those who had ocular conditions affecting visual acuity other than high myopia, and those who had intraoperative complications. Coming to the results, the mean age was 53.2 plus or minus 12.2 years. We had 100 eyes of 80 patients, that is 20 patients underwent surgery bilaterally. Of these, 41 were males and 39 were females. The mean axial length was 29.37 plus or minus 1.89 mm. The mean ACD was 3.47 plus or minus 0.39. 83 eyes was implanted with plus powered IOLs and 17 with minus powered IOLs. We compared the variables in accordance with the axial length, that is into two groups, less than 30 mm axial length and more than 30 mm axial length. And we found that in more than 30 mm axial length, there were more males, that is about 40%, and the mean age was 48 in greater than 30 mm axial length, and it was 55.8 in less than 30 mm axial length. But there was no much significant difference between K reading and AC depth. The overall means preoperative spherical equivalent was minus 12 plus or minus 5.5. The mean preoperative best corrected visual acuity was logMAR 0.7 and postoperative BCVA was logMAR 0.2, which shows a good postoperative outcome following cataract surgery in this high myopes, and which can give which can lead to good refractive outcomes. And the mean IOL power was 6.2 plus or minus 3.6 in axial length less than 30 mm and minus 0.4 plus or minus 2.6 in more than 30 mm group. This table shows the residual refraction plus powered IOLs. Here we can see the BARRET and SRK-T with Wang's-Cox adjusted axial length showed similar results, but with normal axial length, SRK-T is giving hyperopic surprises. In minus powered IOLs, this hyperopic surprises was exaggerated with normal axial length while using SRK-T, but with BARRET and with SRK-T using Wang's-Cox adjusted axial length, it gives similar results. The mean residual refraction with BARRET was minus 0.25. It was 0.65 with SRK-T using normal axial length. It was minus 0.16 using SRK-T with Wang's-Cox adjusted axial length, which is similar to the BARRET Universal 2. Some studies stating similar results. A study by Sang et al. Showed that SRK-T with axial length adjustment can give similar results to the newer generation formula. And another study by Fouch-Shirabi et al. Showed that Wang's-Cox adjustment in the axial length can give similar results to BARRET Universal 2. So concluding, SRK-T with Wang's-Cox adjusted axial length can provide satisfactory results in high myopia as compared to BARRET Universal 2. Since newer generation formula can be used only in advanced machines, those peripheral centers where these expensive machines are not available, SRK-T formula with Wang's-Cox adjustment can be used as an alternative in these cases. In our case, only 15 eyes had UCVA of logMAR 0 and 35 improved to logMAR 0 with correction. So rest 50 didn't improve to logMAR 0, so we couldn't use the postoperative refraction for comparing the performance of these two formulas. So we did a logistic regression analysis to find out the factors which affect the postoperative vision, and we found that axial length, CNVM, and myopic macular degeneration with posterior staphyloma was associated with postoperative low vision, and it was found to be statistically significant. These are my references. Thank you.
You also correlate when any of these newer machines,
Sorry, sir.
newer machines, IOL machines, did you correlate when you have this correction?
Yes, sir. We did the residual refraction using IOL master only. Like we did the residual
What
refraction.
version was it used? IOL master?
700.
700.
Yes.
Okay. So was it?
We actually repeated the biometry with SRKT with the normal axial length and the Bangkok adjusted axial length using IOL master
And
700. Yes.
Okay.